Hello, good morning to everybody. My name is Javier Artal. I'm consultant neurologist working in NHS Highlands. Thank you to NDN, to Emma, and to the whole team for this keen invitation to share with you my view about MS research and what we have been doing in the last 10 years in the Highlands. So why we start with a research program in multiple sclerosis? First, because MS is the first cause of disability in younger people. And I think this is pretty relevant because the impact of MS from a societal perspective on an individual basis and other hidden implications like mood, cognition, mobility restriction is pretty relevant. And MS is highly prevalent in Northern Hemisphere, and we went in to understand what was the real problem in the Highlands. So for this reason, we started initially with a set of epidemiological studies to understand the real incidence and prevalence of multiple sclerosis. And we wanted also to understand what we were doing at that time regarding early diagnosis, early treatment, because these were the opportunities to try to change or to modify the natural history of the disease. So the Highlands is a quite geographical dispersed area. Also, we are basically based in Inverness. One of the things here in the Highlands is that we have a huge number of people living pretty far away from Skye to Thursday. And we went in to check if there were any inequality of care or inequality in the access of care in multiple sclerosis also in our region. So after thinking about this, first we went in to understand the real implications of the prevalence, and then we started with a project to analyze the prevalence and incidence of MS and there in order to clarify the real epidemiological problem in the Highlands. So what we discover is first a gender effect. So the incident cases of MS, almost 88% are women. So I think we are missing the gender effect in the research and the care also regarding MS. And you can see that this is affecting a younger population. So new naive patients are usually diagnosed at age 40. However, you can see that the prevalent cases are on average 54, so they are elderly. And still there is a gender effect that we are always forgetting, as 75% of prevalent cases were also women. However, you take a look here in detail when we analyze all the stratification data, in particular in women cases between the age 40 to 70, you can see that the crude prevalence is even 700 cases per 100,000 inhabitants. So this is a massive impact, huge numbers in the group of young women affected by multiple sclerosis. So these were the numbers, and then we decided to switch from numbers to people with MS. How to manage this? I'm a clinician. So I'm in favor of applied research. So I like molecular biology, but I'm a clinician, so I need to focus in the care of these patients. So for that reason, we started to think how to improve the care, and we started to analyze the time between diagnosis and the time in which we are starting to offer appropriate care and appropriate disease-modified therapies for these patients. And I think one important message here is time matters in multiple sclerosis. We know this in stroke, in acute stroke, and many people argue that time matters in acute stroke has been probably the philosophical approach to develop fibrinolytic treatment in acute stroke. However, for me, MS is acute MS, and we are missing opportunities in order to start with highly diseased therapies from the early beginning. So here, this is one of the analysis of the project. So we're missing opportunities here. The mean time from diagnosis, from symptom onset to MS diagnosis is around 40 months. So this is a big problem, the delay in the diagnosis. And the mean time between symptom onset and the assessment by any neurologist is 28 months. So this is a big delay. This is a big opportunity that we have to reduce this time in order to do things better. So, and there are other important questions here. At the time of these studies, we realized that there were not so many people taking disease-modified therapies we can understand some concerns in people with mild MS or in people planning pregnancy in order not to take disease-modified therapies. But still, the lack of awareness about the prognosis was also another important factor regarding the making decision process, and the lack of access to proper information to make decisions about the best therapies that we could offer to people with MS. So, and this is also a part of our Highlands story, but this is part of a whole picture with this Scotland and the data that we have from the MS registry, also showing the high incidence of MS across the whole Scotland. So, and this, how this relate to our practice, what we did with this information. So it has not been very easy in these last 10 years, but what we decide is to implement highly active MS clinics, joint clinics with MS nurses. We develop infusion suite capacity to offer highly active biological therapies for early naive patients. And then we start to develop the MS Research Center, the MS Clinical Trial Facility Unit as a part of the project to try to help people with MS. And this is important because there is one concept that we want to explain with this therapeutic inertia, which is unfortunately quite common. And this has been defined as the lack of treatment initiation or escalation when there is evidence of disease activity, right? And unfortunately, many people don't realize that if we are coming late to diagnosis, we should not come late to start early these patients, because we can modify disease progression, we can prevent disability progression there. And for this reason, this has implications regarding the reformulation of the clinical work that we are doing. And so, what are the unmet needs when developing clinical research or clinical trials in multiple sclerosis? The first thing is, unfortunately, we don't have yet effective therapies to prevent disability progression. We don't have therapies regarding remyelinization there. We still need more effective therapies, safer therapies in relapsing multiple sclerosis in order to avoid disability progression. Now we prefer to use the concept of NIDA, no evidence of disease activity, with this a better understanding of the whole picture of multiple sclerosis. And we need better biomarkers in order to predict how will be the progression of the disease. So for this reason, we were involved in both clinical trials and real-world evidence study. Both are necessary. There is no competence between these. Clinical trials are important for analysis of efficacy, but real world is what we are seeing. People quite complex, heterogeneous groups, and we can discover safety issues with many highly active biological therapies, and this we can be analyzed only years after treatments. So for the reason, in the MS clinical trial through this year, we started to participate in clinical trials and in observational studies with biological therapies. This is a list of them. However, COVID came here and COVID pandemic is here, right? So I think the message here is the completely disaster on MS research during the COVID pandemic. As many clinical trials were canceled or postponed, many research nurses were deployed to the either COVID trials or COVID wars. But this is not history. We are now in the post-COVID situation in which, unfortunately, we have limited access to MRI scanners, limited access, because the priority is the waiting list for NHS perspective, and the research in multiple sclerosis is giving a slip down, right? So this is an important consideration that we need to change here. And of course, in addition to this, academic studies are not academic. We need to reevaluate the role of biomarkers and also the role of the therapies for symptomatic treatment that we are doing, because still we don't understand if the classical therapies that we are doing are effective or not. So just to summarize, there are some big unmet needs in research. We have been forgetting the treatment of chronic symptoms in multiple sclerosis, as you can see on the left side. The gender effect is pretty relevant too. The lack of proper remyelinization agents, in particular in spinal cord lesions or optic nerve, is pretty important. And we don't understand well if there will be any role for combination therapies plus neuroprotective therapies here. So there are big unmet needs in research, and for the reason research in multiple sclerosis, in my view, cannot be forgotten. So in conclusion, I think we need to put everything into the context. People with MS are living longer. There is increased prevalence in multiple sclerosis. People with MS are having chronic symptoms that we are not focusing adequately. And for this reason, from a clinician point of view, we need to develop specific MS services in order to offer care about this. And in parallel, we need to develop and to be engaged in clinical research programs for people for MS thinking in the long term. Many thanks.